nutrition. Here again is Dr. Gary Marshall.
Thank you. We're going to finish out some of our critical care here and talk about nutrition and surgical nutrition. Again, I have nothing to disclose with regard to the nutrition as a topic. Some of what we're going to talk about is just the basics of nutrition and substrate. Then get into some of the clinical scenarios, parenteral versus enteral nutrition, the basics of parenteral, look at refeeding syndrome, which is a good sort of clinical scenario to bring up as a test question. Early versus late enteral nutrition, some of the immune-enhancing formulas, and then some of the sort of things that get argued about whether the gastric or small intestinal feeds are better. And then how do we assess nutrition, and how do we know that we're doing an adequate job of that? First off, first part of any thing is going to be your assessment, so we'll talk about a question. So all of the following variables are included in the Harris-Benedict equation except age, gender, body mass index, weight, height. Body mass index, that's correct. And sort of looking at testmanship here, weight and height are what are used to calculate BMI, so you wouldn't have an occasion with all of these. So just whenever you are not sure on something, looking for clues like that to like increase your chances or your odds by eliminating a couple extra answers. So the objectives here are to appreciate the rationale for nutritional support and its importance in the critically ill population and the general surgical population. Also to describe basic nutritional needs assessment, the pros and cons of both parenteral and enteral nutrition regimens, and then how to describe how we monitor the results of a nutrition regimen. So rationale, early feeding, it attenuates the metabolic response to stress in trauma and in other things. We want to get that patient fed early. Having that food present does help to decrease the stress response. It prevents oxidative cellular injury and also modulates the immune response. In starvation, you go into a very much decreased metabolic rate. You increase your glycogen utilization. These, again, are largely stored in the liver as starches and can be pretty much consumed. There's about 2,000 calories worth within a day or two. It increases the breakdown of triglycerides and protein to produce glucose in the liver. Again, breaking down this protein becomes very important. We want patients healing and to have that protein on board to heal and fight infection and do all that. And if we're robbing that to make sugar, it's kind of a waste. The brain begins to use ketones for fuel. And this is an adaptive response, simply a survival mechanism to deal with periods of low caloric intake. So the initial assessment, this is all sorts of anthropometric data, height, weight, past medical history, prior operations, and home medications. Again, these can affect nutrition. There can be ramifications related to medications. Current stressors, injuries, and medications. What's going on right now? How is their organ function as a whole? This is important in determining some of the things you're going to do. Physical exam, and then you need to start getting a ballpark of the anticipated amount of time without oral intake. And this will become important in some of those STEM questions as you're deciding, it might be presented with patients, and what you should do about their nutritional status either in the preoperative or postoperative period. Initial assessment body weight calculations. So again, as we talked about in another lecture, the rampant obesity, these become hard to determine. We have both the actual body weight, the ideal body weight, and an adjusted body weight. So these are all numbers that can come into play at different areas. So the actual body weight is just what it is. Ideal body weight in males is 106 pounds plus 6 pounds per inch above that. In females, it's 100 pounds plus 5 pounds per inch above 5 feet. So when we're adjusting, we have to add back in or adjust for that extra adipose mass. So when the actual weight exceeds 120% of ideal, you take the actual minus the ideal multiplied by 0.25 and add that back to the ideal body weight. So basically you're taking 25% of that excess weight and adding it to an ideal body weight to use as your adjusted calculation. This will determine caloric needs and other things. If you were to say take someone who weighs 350, 400 pounds and say, I need X amount of calories per kilo, you would be overfeeding someone dramatically. So this allows you to adjust for actual needs. The Harris-Benedict equation, it's a method used to estimate basal metabolic rate and daily calorie requirements. This is then multiplied by a number that corresponds to your activity and also your certain current level of stress. And then you get your recommended daily calorie intake. And again, it's based on gender, age, height, and weight. With goals in patients in the non-stressed individual, about 20 calories per kilogram is adequate, 0.8 grams per kilo of protein per day. In moderate stress, the caloric needs increase to about 25 kcal per kilogram, and protein now you want at 1.5. So you double up in that stress phase on the protein requirements. In severe stress, again, increase the calories a little bit more, and again, increase your protein. Question, what percentage of non-protein calories per day should be in the form of carbohydrate? A, 40%, B, 50%, C, 60%, D, 70%, and E, 80%. So it is actually 70% of non-protein calories should be from carbohydrates. Again, this flies in the face of all the current dietary fads, but in setting things up within setting a regimen, you first determine the protein needs, build that portion of the calories, then look at what you have left to fill, and you want to do 70% of that with carbohydrate. We'll talk about some of the rationale for that as we progress. So substrates, the basics are protein, carbohydrate, fat, and then your micronutrients. Protein yields 4 kcal per gram for caloric intake. The requirements, again, baseline every day should be about 0.8 grams per kilo. Mild stress, 1.2. Moderate, 1.5. And severe stress, it goes up to 2 grams per kilogram. The goals are based on the nitrogen balance. This is something that used to be calculated a whole lot to getting that 24-hour urine and getting an actual nitrogen balance, but that's kind of gone by the wayside. So the digestion and absorption of proteins. Proteins are taken in. They begin with pepsin in the stomach, broken down into smaller peptides. Then you get pancreatic proteases activated by enterokinase, and this is located in the duodenum. Most protein digestion occurs in the duodenum due to the pancreatic proteases, and it's complete by mid-jejunum. The absorption follows suit. Basically, as it's digested, it's absorbed so that it's also complete by mid-jejunum. Carbohydrates yield 3.4 calories per gram. Again, 70% of non-protein calories per day. This is in calculating hospital nutrition, not to be extended to recommended dietary outside of the hospital. Glucose stores, remember glycogen stores are quickly utilized in malnutrition. These are primarily stored in the liver. And then the liver begins gluconeogenesis. This converts protein to glucose over time. There is a time lag in doing this. Your body's not really set up to be doing a lot of gluconeogenesis at baseline because normally in the fed state it's an unnecessary procedure. So in some of the conversions, 1 gram of nitrogen is what is contained in 6.25 grams of protein. 1 gram of nitrogen equals about 3.5 grams of glucose. So you can see you're breaking down a lot more protein than the carbohydrate you yield. So it's somewhat wasteful in that sense. Minimum glucose requirement is about 150 grams per day, primarily for brain tissue. Carbohydrate digestion and absorption, again, this begins in the mouth with salivary amylase, continues in the duodenum with pancreatic amylase. Carbohydrates are converted to oligosaccharides within the intestinal lumen, and then the brush border associated oligosaccharides then convert these to simple or 2-sugar moieties, which are then absorbed in the intestinal epithelium. Fat yields 9 calories per gram. This should account for 30% of your non-protein calories per day. In total, in TPN, you get about 2 kcal per cc for 20% lipids. There's thought that lipids are immunosuppressive, and there's definitely an increased infection risk. So we lean away a little bit from providing fats, and some regimens will do in TPN fats maybe every other day. This is the biggest source of line sepsis going because of the nature of the fats. And again, it's not always helpful to have this injected into your bloodstream. Remember, through the normal digestive process, we'll talk about totally abnormal going in directly into the bloodstream. And remember, you got to remember propofol. This is pure fat, and you do need to consider the caloric contributions. Again, 150 grams of protein, propofol times 9, you're getting into a pretty decent amount of fats. Fat digestion and absorption begins in the duodenum due to cholecystokinin and the proximal small intestine. This then stimulates all of the pancreas to release its lipases, including cholesterol, esterase, phospholipase, and then the bile emulsifies the fat to facilitate the other action. The triglycerides then form free fatty acids, which are then absorbed by the intestinal epithelium. The long-chain fatty acids are incorporated into chylomicrons, which are then in the circulatory form. Short and medium-chain fatty acids are bound to proteins and transported via the portal system to the liver, so we have a different mechanism. Micronutrient deficiencies, I'm not going to go through all of these and force you to remember them. The way that these are more likely to pop up in questions is not just, what do you get if you don't have enough selenium? Yeah. It's going to be a patient who, say, has had some sort of short gut syndrome or a bariatric procedure or some other cause that now has metabolic consequences. So remember, your B12 is going to lead to an anemia, so you might get a patient with anemic values and realize that they're not getting enough iron or calcium and vitamin D and the bone synthesis and some of the vitamins. Again, still like to pull up relationships of vitamin K with clotting factors and coumadin and how that might affect things in terms of blood clotting and the like. So these are all here. You can review the slides. Just remember some of the big ones. Vitamin K is the clotting. Vitamin D is bone deposition. Vitamin A in the eyes. The various B for metabolism. And B12 for anemia. Vitamin C, again, is collagen synthesis and scurvy. Not something we see a whole lot of at this day and age. Finally, biotin, folate, chromium. None of these are terribly likely to show up, but they're interesting more for ABSITE. They're for your review. Next, moving on to parenteral versus enteral nutrition, and this is a big debate. I know when I trained, everyone got hyperalimentation, and TPN was the winner, and that's kind of where everything went. We've learned better. So in comparing enteral nutrition and parenteral nutrition, which of the following statements is correct? A, enteral nutrition results in better substrate utilization. B, parenteral nutrition results in increased infectious complications. C, there is no significant difference in mortality between enteral nutrition and parenteral nutrition. And D, parenteral nutrition results in increased glucose intolerance. E, all of the above. That's correct. It is all of the above. So the key is, one of the keys here is there's never been a mortality difference shown. There is a much more increased infection with TPN, and then better utilization, better gut stability with enteral nutrition. In addition, the TPN causes, usually you need an insulin drip or insulin right in the bag due to this extreme hyperglycemia that's caused. Again, 70% of your calories come in the form of glucose delivered directly into the circulatory system, can wreak havoc on sort of your blood glucose control. So why is enteral nutrition superior? Better substrate utilization. You're going through the normal pathways in the gut. It does not produce the same level of glucose intolerance. It prevents gut mucosal atrophy. Gut mucosal atrophy can lead to translocation and infectious complications down the road. It attenuates the stress response. It maintains immunocompetence, and it preserves the gut flora. Again, the more and more we learn about the microbiome, the more important this is to maintain. Why is parenteral nutrition so bad? Greater documented pneumonia, empyema, intra-abdominal abscesses, line sepsis, and fasciitis with wound dehiscence. All of these are worse with parenteral nutrition. So looking at the practice management guidelines, this is looking at 13 different studies. No mortality difference between enteral and parenteral nutrition, but enteral nutrition had a significant decrease in infectious morbidity, and therefore, based on this, the committee felt that due to safety, due to cost, due to feasibility considerations, enteral nutrition was favored. So, parenteral nutrition. All the following are indications for TPN or parenteral nutrition except A, high output fistula refractory to enteral nutrition, B, high risk for non-occlusive bowel necrosis, C, massive bowel resection refractory to enteral nutrition, D, after 5 days of inadequate enteral nutrition, and E, immediately postoperatively in the severely malnourished patients. So which is not an indication? So it's actually after 5 days is not an indication. The time frame is actually closer to 10 days. Some studies show as much as 14 that you have potential harm with TPN before that with no clinical benefit. And so that's a lot of the rationale for waiting this long, is that there's no clinical benefit ever documented and you have now increased your risk. So indications, persistent progressive ileus, bowel obstruction, you can't feed these. Massive bowel resection refractory to enteral nutrition. If you have no gut, you can't use the gut. And then high output fistula that's refractory to enteral nutrition. Again, if you're not absorbing anything, you're going to need to find another route. Malabsorption, again, high risk for non-occlusive bowel necrosis, relative selective hypoperfusion, or documented enteral nutrition intolerance. These are all reasons that you might switch to TPN. So failure of enteral nutrition to meet caloric requirements by post-op day 7 is the current recommendation for TPN. In severely malnourished patients, a 70-day course of pre-op parenteral nutrition may be beneficial in decreasing septic complications. So this would be presented, say, as a patient who's coming in for an esophagectomy. They have lost 40 pounds of weight. They've, clearly at 20 to 25 pounds of weight loss in the preoperative period. This is where you run that great benefit of giving them 10 days of upfront nutrition and then going on with your more advanced surgery. You're much more likely to get them through the operation and deal with a lot of metabolic consequences and heal from the operation better. So usually that preoperative category will not be someone who's has a mild degree of weight loss, like 10%, but somebody who has like 20 or 20% weight loss in a short time frame. And usually it's a foregut procedure, usually esophagus or stomach. Those would be where you have that benefit of bringing them in and giving them the TPN. Usually, again, because of these obstructions, you can't use the gut, and you need to get these patients in better shape. Complications of parenteral nutrition include fluid and electrolyte abnormalities. The days of titrating each of these individuals is kind of going away. A lot of these are pre-mixed electrolytes that are not changed daily, so you can run into some problems. Your LFTs will go up, the gut will atrophy due to not seeing any nutrition, and then refeeding syndrome. So the refeeding syndrome. Which of the following about refeeding syndrome is correct? Typically occurs in previously malnourished patients. B, results in rapid decrease in phosphate, magnesium, and potassium. C, results in increase in extracellular fluid volume. D, begins 1 to 2 days following initiation of parenteral nutrition. And E, all of the above. That's correct, all of the above. So an overview, this occurs when a previously severely malnourished patients are fed with a high carbohydrate load. Again, the STEM, when you see this patient, will be someone who is previously severely malnourished. This is not going to occur in someone who's a couple days behind. This is someone who's has lost a lot of weight. It results in rapid fall in phosphate, mag, and potassium, as well as glucose levels. The phosphate is the most critical. This can drop rapidly to a level below 1, and that's as all your ATP starts to rebuild itself suddenly with this carbohydrate load. It will, your levels will go severely decreased. In addition, you have an increase in the extracellular fluid volume, so a lot of fluid moves into the extracellular space. Complications can be anything: cardiac workload due to that fluid loss, stroke work, heart rate, oxygen consumption with potential cardiac failure can occur. Increased CO2 production because you've all of a sudden started metabolizing glucose again after being underfed. With change in the RQ, you can have respiratory failure due to inability to handle that. Other potential, like you can go into rhabdomyolysis, seizures, coma, and then blood cell dysfunctions. The most effective way to treat this is to avoid it. First, you want to identify those patients who are at risk and recognize that up front. 2, you initiate nutrition slowly. Usually that first day or first couple days are given below about half of what you estimate the needs to be. And the final is just watching those electrolytes constantly. You need to be checking those multiple times a day and repleting them aggressively. If they start to tank, you can't assume that just giving one run of MAG is going to do this, or one run of FOS. You need to follow up each of these because the problem continues over a couple days. So you need to be very aggressive. Looking at enteral nutrition. So all the following are absolute contraindications to enteral nutrition except. So this is absolute. Persistent progressive ileus, bowel obstruction, peritonitis, massive gastrointestinal hemorrhage, and splanchnic hypoperfusion. So splanchnic hyperperfusion can be a contraindication, but it's a relative one, and so it has degrees. The others are absolute contraindications. The patient's got ongoing peritonitis. You don't until you know it's not a hole in the gut. You can't feed that. If the gut's obstructed, you can't feed. These are all just absolutes. So indications: inability to retrieve adequate oral intake. A lot of the targets now are to be up at 80% of caloric needs within 48 hours, if possible. Acutely ill patients, chronically malnourished patients, and those with limited reserve. So again, the absolute contraindications: persistent progressive ileus, bowel obstruction, massive GI hemorrhage, and peritonitis. So the relative enteral nutrition intolerance, this is sometimes measured with residuals. That's not really a good way. Residuals don't matter so much as whether the patient's regurgitating or just can't tolerate it, or cramping or having pain. Massive bowel resection, high output fistula, pancreatitis, inflammatory bowel disease, and then splanchnic hypoperfusion, depending on the degree. There are all sorts of tube-related complications. Most common of these is they either get dislodged because somebody put a whole pill down them in the hospital and instead of grinding it, or patient pulls them, and this is a chronic problem. Bowel necrosis can occur, small bowel perforations from the tip, small bowel volvuli and infarction due to the presence of that catheter, intraperitoneal leaks, and tracheobronchial aspiration. It is a small fine tube usually, but it is stenting over the lower esophageal sphincter, so patient flat on their back now has lost some of their protective mechanism and can have some aspiration events. GI-related complications, again, high gastric residuals. Now in modern time, we're calling that like 500 cc's, and it has to be present with symptoms before we'll do that. Nausea, regurgitation, vomiting, cramping. Some of these are hyperosmolar, and they cause big fluid shifts into the gut, and they can be uncomfortable. Constipation or diarrhea. There are some now fiber-containing formulas, and then just distension. So access can be nasogastric or orogastric tubes. Nasogenital feeding tubes are possible. These can be done either by a push method or endoscopically. And this is just putting that tube in the nose and trying to get it all the way past the ligament of Treitz. Nice if you can do it, but again, pretty difficult to get a flimsy tube that far beyond. PEG tubes, PEG J's, and then jejunostomy, whether it's open or laparoscopic. So this is just a sample advancement protocol starting at 15 cc's an hour for 12 hours, then increase by 20 every 4 hours to hit goal. Most of the formulations today are 1.2 or 1.5 cals, so the volume required is much less than it used to be. Almost all the formulas originally were 1 cal per cc. Now they're up to 1.5, so you can pretty rapidly get up to goal at a low volume. And then you can assess the residuals if fed gastrically. Usually this should be driven by symptomatology rather than just residuals. High residuals without symptoms are a frequent cause of not getting enough nutrition because the bedside nursing is constantly holding the tube feeds when it probably doesn't need to be held. And you don't check in the gut residuals in the jejunum. There's no point in doing that. So looking at early enteral nutrition, this means getting calories within 48 hours. So this does what's the following? Early nutrition. A, attenuates the hypercatabolic response to trauma. B, improves wound healing. C, modulates the immune response. D, preserves GI function and structure. Or E, all of the above. That's right, all of the above. So all things we want to do. So why? The hypercatabolic response is attenuated and it improves nitrogen balance. So you go away from both needing more proteins and from breaking protein down to make glucose. All of this is helpful. It improves wound healing and immune function and decreases infections later on. And then it preserves the GI function and structure. The gut mucosa relies on its nutrition from the actual lumen of the gut and doesn't get it as much from the blood supply. So having no presence of food in the alimentary tract can be harmful to the gut itself. And that's why we sometimes talk about trophic feedings, which are just at half the rate or 30 cc's, just to provide the gut with some stability. It may not meet your nutritional goals, but it preserves gut function. Also, decreased hospital length of stay, but no difference in mortality. Indicated major head, torso, or abdominal trauma, any major upper GI surgery that precludes oral intake for 5 days, second or third degree burns greater than 20%, or chronically malnourished patients who you think are going to be without oral intake for more than 5 days. So these are less than 80%. Ideal body weight, muscle wasting, history of chronic suboptimal intake. Those are the standard kind of definitions that will be presented in that STEM for patients who need, more nutrition, early nutrition, and the like. Significant comorbid disease such as COPD, high bilirubin or hepatic insufficiency, renal disease, AIDS, chemo, steroids, active malignancy, all these are indications for that early enteral nutrition. There are some immune-enhancing formulas. So we'll talk about some of these. Immune-enhancing formulas result in all of the following when used in the appropriate patient except A, decreased infectious complications, B, decreased hospital length of stay, C, decreased mortality, D, all of the above, E, none of the above. So, right, there is no decrease in mortality that's been demonstrated on any of these nutritional studies. Immune-enhancing formulas contain glutamine, arginine, the omega-3 polyunsaturated fatty acids, and nucleotides. There's no one different, every brand has their own special immune-enhancing formula. These are not required in everyone. They would love to have you believe that, and actually in some cases may be harmful. So they do have some reduction in infectious complications and reduced length of stay in the hospital. So indications, here's just some lists that have come up with literature. Combined flail chest and pulmonary contusion where you're going to be on the vent for more than 72 hours. Again, here your risk factor is for pneumonia, and so that's why you might want the immune enhancing. Abdominal trauma index greater than 18. This is just very severe abdominal trauma. And then 2 or more of the following: major pelvic trauma, 2 or more long bones, and greater than 6 units of transfusion. All of these are just markers for a severely injured patient. Non-trauma patients, so like major cancer operations, and you believe you're at risk for septic morbidity, would be an indication. Moderately malnourished patients with major operations in the gut, and then severely malnourished with even lesser operations, simple colectomy, elective, or rectal anastomosis. So finally, looking next on the gastric versus small intestinal feedings. Varying results on whether to feed in the stomach or post-pylorically. Most post-pyloric tubes are too short to ever get beyond the ligament of Treitz, so just simply feeding D2 and D3 is not all that helpful. You're stenting open the pylorus, so we'd hope for more benefit in that preservation and cut down in aspiration events, but it really, with it just delivered into the duodenal bulb or right around the corner, it doesn't help. If you can get beyond the ligament of Treitz, and this is something you can do sometimes by passing the tube, say if you're operating on a patient, to pull it down manually and get it beyond there, then it's great. And if you can do that, you do see a benefit. There is a high incidence of duodenal gastric reflux on these. Small intestinal feeding, though, did result in a more rapid and successful delivery of nutrition. You're not checking residuals. You're just able to get there a little faster. Some small studies suggest decreased infectious complications, and again, no difference in mortality. So in special situations, there are 1 million tube feeds on the market. If you talk to these reps, they have a tube feed for everything. But in renal failure, you can use standard tube feeds. Hepatic failure, standard tube feeds. Pulmonary failure, same standard tube feeds. And then pancreatitis, you can still use standard. Only some of the immune enhancing formulas have been shown to have benefit. The renal formulas can be of a little benefit if you're having volume issues, only because they're 2 calories per cc instead of 1.5, so you give a little less volume. Other than that, there's no scientific or clinical benefit shown in any studies for any of these. They are very pricey, all of them. Looking at nutritional assessment, how do you know if you're malnourished, or how do you know if you caught up? The respiratory quotient, when the predominant fuel being utilized is carbohydrates, is A, 0.5, B, 0.7, C, 0.8, D, 1.0, or E, none of the above. And respiratory quotient is CO2 produced per oxygen utilized. It's 1 to 1, actually. That is correct. 1.0 is the answer. So looking at different parameters, looking at normal, mild, moderate, severe deficits. In that normal, you're greater than 90% of your ideal. Your albumin's over 3.5. Prealbumin is over 18. Transferrin is also over 200. C-reactive protein, an indicator of stress, is going to be 0. In a mild deficit, say you're at 80 to 90% ideal, your albumin is now 3 to 3.5. Transferrin is decreased. Prealbumin in the 15 to 18 range. And C-reactive protein will start to go up and indicate mild stress. Moderate deficit in the 70 to 80% of ideal body weight. Albumin is now 2.4 to 2.9, and C-reactive protein up to 20 to 30. And the prealbumin is down to 10 to 15. And then severe malnutrition, prealbumin, most commonly used test, is under 10. C-reactive protein indicating severe stress, greater than 30. And then again, albumin now less than 2.3, indicating very depleted protein levels. So nitrogen balance, if this were to come up, is nitrogen in minus nitrogen out. You take the protein in, again with TPN or with gut formulas. You can just read the label, know the volume you gave, you know exactly how much nitrogen you gave. But it's protein grams divided by 6.25 minus nitrogen out. This is 24-hour urine, urea, and nitrogen plus 4. And you want a net balance of plus 2 to 6 grams of nitrogen. If it's losing more of that, you're not achieving adequate nitrogen balance. This is less likely used than when we were in training, and again, not likely to come up as a question to calculate nitrogen. Indirect calorimetry, or the metabolic cart. This was actually just hooking someone up and using the ventilator circuit to measure exactly how much oxygen came in for a period and how much CO2 came out. You just hook the gas circuits up, the inflow and the outflow, and calculated this. This allows you to get the basal metabolic rate and how many calories were being used, and also to determine the RQ. These were useful in getting that respiratory quotient to determine the caloric composition of the feeding you should be using. So an RQ of 0.7 suggests lipids being used. Again, fat breakdown produces the least CO2. Carbohydrate on the other end is 1.0. If your RQ is greater than 1, you're probably depositing fat. And then mixed fuels is about 0.8, 0.85, show that protein, carb, and fat are all being utilized. And so this is sort of your target is in that range. So the objectives here, again, are to determine that resting energy expenditure and guide appropriate support, and actually determine that allows you to tailor your patient to their needs. Again, in previous periods where the goal was hyperalimentation or getting higher than normal calorie intake, you could run into ventilator weaning problems. You'd have this RQ of 1, meaning you're feeding the patient too much of their calories by carbohydrate, reducing that carbohydrate load, reduced CO2 production, and it made it easier to wean from the ventilator. So you want to just measure each of these things again and then look at that substrate utilization. That's all. This is one of the first ambulances at Bellevue where I'm working right now. This sits in the lobby today. Getting back just into the summary on the nutrition, some key elements to remember are who needs that nutritional upfront. I would see a patient being presented as severely malnourished, getting ready to undergo a major surgery, usually cancer operation, that needs those calories in that 10 days preoperatively. Patient who comes in that lesser degree of weight loss, maybe just 0 to 10%, coming in for a basic, say, sigmoid colectomy or one of the other like procedures, does not need that upfront nutrition, and those can be managed by quick, early, post-operative enteral nutrition following most of the colon guidelines, meaning just because they lost 5 or 10% of their weight doesn't mean you need to treat them special, and the best bet there is just to get them fed ASAP after the operation as soon as they can tolerate it. In addition, looking at somebody, it might be presented with a patient and determine how much you're going to give, so you might want to figure out the caloric needs in that 20 to 25 range based on kilos, 70% carbohydrate, how much protein do they need. Usually be obvious as to whether the patient is highly stressed or not. It's not usually going to be in the middle and saying that this is mild. This is moderate to mild stress. It's either going to be someone who's burnt over half their body or has a list of injuries, as long as your arm, that has clearly high needs. How would you design or go about setting that initial formula? And so that's where knowing some of that caloric needs based on kilos, stress factors, and how much protein the patient needs. Sir? I want to know if we use the NG tube. I usually start with the NG tube while it's in place, especially if they're on the ventilator or something like that. If it's going to be long-term, switching to Dobhoff or the like, or a smaller tube, is much more comfortable for the patient because it's softer, it's less likely to cause nasal erosions, a little bit less stenting open. But that's a risk on all of them, is that lower esophageal sphincter, and that's where maintaining the head of the bed greater than 30 degrees is very helpful when you've done this, because you've a lot of people say they're preventing aspiration by keeping that NG for longer periods of time. You may be causing it, aspiration with that tube. Sir? No, we would continue to do that. Sometimes you would maybe hold them for a little bit less, and then in that case decide, okay, they passed their trial, now we'll hold the tube feeds and extubate in 4 hours, rather than holding them before every single trial. Only hold them after the successful trial on the day you're going to extubate. Can avoid some of that. You just want to know what to do when a patient's having their nutrition interrupted on a daily basis for their spontaneous breathing trial, how to avoid that nutrition loss. We don't routinely stop the tube feeds before the trial. We only stop them if they pass the trial. Okay, I think there's some nutrition waiting outside.